Can you explain the red zone and white zone, what that means and why it matters so much?
Yes, of course. So the meniscus in of itself has no blood vessels going to it. So the meniscus in the meaty part right here, has no blood flowing to it, and that's called the white zone. The periphery out here has blood flowing, and that's called the red zone. So a tear, for example, in the all white zone, in the meaty part here, has a much less likelihood of healing if we repair it, as opposed to a tear, for example, that may be here, that's in the red and white zone, where we can suture it and incorporate a lot of the vasculature. Because again, for healing, it's very important that we have approximation, bringing two things together as close as possible, good fixation, making the approximation solid, so there's no movement, and blood flow. All the healthy nutrients for healing needs to come. So if we approximate a white on white tear and make the fixation great, but there's no blood flowing to it, won't heal, or at least the likelihood is very small.
Is there ever a case where a white tear zone is worth trying to repair?
That is a debatable issue. More and more people, with the advancement of new fixations that are really very strong, being a little bit more daring and repairing some of the more white on white tears. It is particularly more potentially effective if the meniscus repair is done during an ACL reconstruction, because when we do an ACL reconstruction, we do a lot of drilling in the bone, and blood, all the nutritious stem cells come out with the blood from the actual bone marrow, and that promotes healing. So there's a higher likelihood of healing of a meniscus repair during an ACL reconstruction as opposed by itself. But the short answer is that there's a dramatically, it's unlikely and uncommon to repair a tear that's exclusively in the white area.
Can you tell the zone from MRI, or do you need the arthroscope?
We can make an educated determination, but unfortunately, definitively, we don't know until we're in the operating room doing the arthroscopy and probing the actual meniscus. So we actually need to feel it. So we're in the operating room, the tear may have looked somewhere in this area here, but when we're in the operating room, I'll put a probe, an instrument, to feel exactly the tear, and I'll find that it actually extends all the way back to the blood flow. And then wonderful, because now we can preserve that meniscus instead of taking a portion of it out.